Welcome everyone to our seminar today. The topic is tips for using antipsychotics in dementia. This project was facilitated by the California Culture Change Coalition under contract number 13-20-555 with the California Department of Public Health and funded by the Centers for Medicare and Medicaid Services for the California Partnership to Improve Dementia Care. My name is Martha Pauley. I'm a faculty member at California North State University College of Pharmacy, a board-certified psychiatric pharmacist and certified geriatric pharmacist. I've been a long-term care consultant for many years. I have no relevant financial relationships to disclose. So what are our goals for today? Well, as pharmacists, we can advocate for and be an advocate for delivery of healthcare that is person-centered and goal-directed. And specifically today, we're going to talk about appropriate use of antipsychotics for behavioral and psychological symptoms of dementia. So CMS, as you know, has reported that the use has decreased since their directives. The goal by the end of 2016 is a 30% decrease. We have more room for improvement. California ranks in the top 15 states for improvement, but we're still moving forward. What are some drivers of antipsychotic use in patients with dementia? In other words, what is the old paradigm? It has been an historic practice. Specifically, Haldol has been used frequently for delirium and agitation. Other treatments have limited success. We don't have a perfect treatment out there. Comfort may override function or log levity in patients as the primary goal in many patients with dementia. We have distant prescribing physicians that aren't actually on site. We have a prescribing culture that's quite unique. In the United States and in skilled nursing facilities, it is more customary to add a med for a problem, and patients may come in on antipsychotic meds. Some incentives do not provide real resources to reduce the use, and often these incentives encourage documentation to justify the current use within the guidelines rather than to make changes. What are some appropriate and inappropriate indications for antipsychotics? As you know, appropriate uses include schizophrenia, schizoaffective disorder, bipolar disorder, and depression as an adjunct. Also, it's appropriate to use antipsychotics in psychosis associated with Parkinson's or Huntington's disease. In Parkinson's disease, quetiapine and clozapine are usually used because they're least likely to cause movement disorders. And in Huntington's disease, antipsychotics sometimes treat the hallucinations of Huntington's disease, even though we have a concern about worsening bradykinesias that even with atypicals use at low dose. Antipsychotics might also be used for autism spectrum disorder or Tourette's. And then there are the occasional medical uses in illnesses with psychotropic or psychotic symptoms and in short-term use for nausea and vomiting associated with cancer chemotherapy. Inappropriate use is for the things listed here, for sleep, for appetite stimulation, wandering, restlessness, nervousness, and other subjective symptoms like this, uncooperativeness, and poor self-care. And then we have a condition or an area called that depends. So what about the use in dementia or in agitation or aggression? These are some of the things that we're going to talk about today. First generation antipsychotics are listed on the side, fluphenazine and haloperidol being the most common that still have some use today. And you can see that by looking at the tables as they go across, there are varying propensities to cause different types of side effects. So let's take Haldol for an example. 3 pluses means that it's very likely to cause EPS or extrapyramidal symptoms. It's not very anticholinergic when you look across to that column because there's a plus/minus. It does cause some sedation and hyperprolactemia. So looking at some of the older drugs such as chlorpromazine, second from the bottom, higher propensity to cause metabolic syndrome, anticholinergic side effects, more sedation, and orthostatic hypotension. So there are some differences among the antipsychotics. Now let's look at second generation antipsychotics. Looking at them with the same schematic, we can see that they do have less propensity to cause EPS. The one exception might be risperidone that you see there with 3 pluses. They do cause more risk of metabolic syndrome and varying degrees of anticholinergic side effects, sedation, and QT prolongation. So these tables are provided just for a quick review of these first and second generation antipsychotics and what symptoms or what side effects may be problematic in certain patients. So what are in general, the potential toxicities with use of antipsychotics in dementia? Well, we know EPS, and we also know QTc prolongation, and this is especially important when we're talking about drug interactions. Most of the studies that have been used to delineate these side effects are done in extrapolated from adult studies, so it's not as clear how they relate to people with dementia, but we generally assume that these risks are greater in the elderly. Excess sedation and cognitive decline especially, risk of falls, and then we're all familiar with the black box warning of increased mortality. So this is basically from 2 general sources, pneumonia and cerebral vascular events. And this is with typicals and atypicals, or with first generation as well as second generation. The highest risk for the black box warning is shortly after medication initiation. And then another risk is venous thromboembolism, primarily with atypicals. So as you know, all antipsychotics are on the Beers list, where stroke and cognitive decline are cited in persons with dementia. And of course, the Beers list states that cautious use is prudent in people with after behavioral interventions have failed and when there is substantial danger to self or others. So we're going to elaborate on these points. What are risk factors for EPS? Well, old age is the biggest one. High doses of antipsychotics more commonly cause EPS, longer durations of therapy, in particular when we're talking about tardive dyskinesia. Females are more at risk than males, and comorbid conditions such as mental retardation or other physical illnesses, medical illnesses, also increase the risk. And Haldol has notoriously had the highest rate of EPS. But we need to point out again that atypical agents can cause EPS. The lowest rate for causing EPS would be with clozapine, and the highest rate would be with risperidone. So let's look a little bit at these EPS more specifically. Dystonia is a common one in younger and male patients, so not as much of a problem in the elderly, but remember this is a prolonged spasm or abnormal posture that can occur pretty soon after the initiation of the drug, onset within 24 to 96 hours of start or dose change. Treatment is anticholinergic therapy with diphenhydramine or benztropine, either IM or PO. So that isn't as significant a concern for us as is pseudo-Parkinsonism. Pseudo-Parkinsonism has many of the hallmark symptoms and signs of idiopathic Parkinson's disease: the masked facies, the stooped posture, shuffling gait, tremor, and bradykinesia or akinesia. The greatest risk here is advanced age, and it's the most common EPS in the elderly. Onset can be days to weeks after starting the drug, and the treatment really is to stop the drug as the primary mode, but also one could consider decreasing the dose, changing the drug, or using anticholinergics, possibly in the younger of the elder group, not in those of advanced age. The second EPS we're going to discuss is akathisia. So this is an inner restlessness, a fidgeting, distress, or the ants in the pants syndrome that some people describe as just not being able to sit down or stay still with the urgency of moving. It may be mistaken for worsening illness instead of a drug adverse event, with the opposite of what you would want to occur happening. So there is a risk that the antipsychotic agent could be increased rather than decreased or stopped. The greatest risk are those of advanced age, and females. It is dose related. Onset can occur within a few weeks to months of therapy start. And as we mentioned, first generation and second generation agents are both responsible 1-to-1. The treatment, of course, is to stop the drug. And then depending on other circumstances, dose reductions, beta blockers, benzodiazepines, or a changing of the drug may be a consideration. But stopping the drug is definitely considered preferred. Tardive dyskinesia, the last form of EPS, is really the worst case scenario EPS. Generally a permanent condition, it can occur after months or years of therapy, and it remains an issue even with the second generation agents. The greatest risk is advanced age, non-Caucasian race, females, and those with a history of either diabetes or organic brain damage. There are possibly other pharmacogenetic factors involved. Polymorphisms of the dopamine-related genes have been mentioned as contributors to this supersensitivity to chronic dopamine blockade that occurs. These are involuntary rhythmic spasms, usually of the face and tongue, but can also be head and neck, hand and arm. They're very debilitating. They're embarrassing. They're relentless. They cause social isolation, and they decrease quality of life. So the management for tardive dyskinesia is prevention, stopping the drug, changing to a second generation agent with less propensity for this. Anticholinergics are not recommended. What are some non-pharmacologic strategies for behavioral problems? One of the first things that we can do is recite the ABCs. What's the antecedent? What's the behavior? What's the consequence? Having knowledge of these three factors might help us in formulating a plan. Also discussing social issues. What about grief and loss? These are common conditions in the elderly. These may play a role in coming up with a strategy for behavioral problems. Make sure that obviously we need to treat medical causes and pain. Avoiding isolation, keeping to good practices as far as daily routines is important. Promoting music and occupational therapy, ensuring good sleep hygiene, which we're going to discuss a little bit later, and then providing comfort, hunger, pain, and safety assessments on a regular basis. These may provide visual cues when done frequently that help us use these strategies well. More non-pharmacologic strategies, using a daily schedule and a toileting schedule. Watching out for the environmental triggers, as we said, maintaining a calm demeanor as the care provider, using caregiver support groups, promoting walking and light exercise. Pet therapy is sometimes used. These are animal visitors. Sometimes there's even a house animal on the property or in the facility, and groups such as Lend a Heart are visiting commonly in skilled nursing and assisted living facilities and are very popular with the residents. Also simulating a family presence with either videos, tapes, pictures, walls of familiar objects, and music from familiar times are important strategies. One helpful acronym that I like is PHALT, P-H-A-L-T-T. So assessing for these conditions is important. What about pain? What about hunger? Is there anxiety present? Is there loneliness, toileting needs, thirst, and tiredness? This is a good acronym for covering all the bases as far as looking out for things that we need to consider before using drugs for dementia. These unmet needs may manifest as inappropriate behaviors. And if the treatment team can link to one of these, then we can make some specific recommendations that are helpful. I wanted to bring to your attention the Choosing Wisely program. So this is a program from the American Board of Internal Medicine Foundation in partnership with the Council of Medical Specialties Societies. It's designed to support practicing physicians and advance professionalism. There are about 70 specialty society partners, and each one has listed some Choosing Wisely statements that they think advance a national dialogue on avoiding wasteful or unnecessary tests, treatments, and procedures. So we're going to talk about some specific ones from either the American Psychiatric Association or the American Geriatric Association or other related groups that apply to us today. And this first one is don't use antipsychotics as the first choice to treat behavioral and psychological symptoms of dementia, promoted both by the APA and the AGS. And their statement is below. But we know that people with dementia have some aggression or resistance to care or other challenging behaviors. But using these drugs should be limited to cases where non-pharmacologic methods have failed and patients pose an imminent threat to themselves or others. And they also point out that identifying and addressing causes of behavioral change may make drug treatment unnecessary. Another choosing wisely statement that applies to us today is don't prescribe antipsychotic medications for behavioral and psychological symptoms of dementia in individuals with dementia without an assessment for an underlying cause of the behavior. This choosing wisely statement comes from AMDA, or the Society for Post-Acute and Long-Term Care Medicine. So very similar statements. They promote careful differentiation of the causes of the symptoms and attacking those things first, and then if other treatments are unsuccessful, to consider antipsychotic medicines, taking into account their significant risks compared to benefits. And they also mention obtaining informed consent. The third choosing wisely statement that applies to us today is don't prescribe antipsychotic medications to patients for any indication without appropriate initial evaluation and appropriate ongoing monitoring. And this one is from the American Psychiatric Association. In the text, they mention individual initial evaluations, ruling out other illnesses, thorough assessment of the underlying causes, family history, and then appropriate ongoing monitoring includes continuous reevaluation and documentation of dose, efficacy, and adverse effects. And keeping in mind, what is our target assessment or symptom? How does that relate? Is it being improved? Are we assessing for movement disorders or other neurological symptoms? We've really covered three choosing wisely statements. The first one talked about using them not as a first choice. One talked about making sure that we had appropriate assessment, and the other one talked about appropriate initial evaluation and ongoing monitoring. These can all be found easily on the American Geriatric Society website with other additional statements that are made there. So when we're considering risk and benefits of off-label use of antipsychotics, we really understand that the scales are tipped. The risks do exceed the benefits in many cases. Let's look at antipsychotic mortality risk. These authors examined mortality risk of individual agents in a retrospective cohort study with data from the U.S. Department of Veteran Affairs in the years 1999 to 2008. They looked at outpatients 65 and older and approximately 33,000 patients. When they looked at these individual drugs, they found that haloperidol or Haldol had the highest risk. And actually, the first 30 days was the highest time risk, and then it declined. When looking at the other agents, the risk was greatest in the first 120 days and then declined in the subsequent 60 days. So risperidone was next high, then olanzapine, then valproic acid, then quetiapine. So they did use an anticonvulsant as a marker, just as a non-antipsychotic comparison. It's not clear why quetiapine had the lowest risk. And we also know when looking at valproic acid that anticonvulsant use in the elderly may also be associated with problems, somnolence, thrombocytopenia, fractures. Here's a graphic representation of what we just talked about, and you can see that the purple line, the haloperidol line, has the lowest survival probability or the highest risk in this 180-day period. And you can see that the line precipitously drops the most severely early and then levels off, as we've mentioned. So this graphic representation just helps you see what we've just discussed, with the green line being quetiapine having the least risk for mortality. Let's look at another review. This review is a meta-analysis of off-label use in adults. the efficacy and safety were reviewed. This was a study through 2011, and eventually 162 studies were formed part of the data. So one of the main conclusions was that benefits and harms do vary among the atypical agents. They looked specifically at aripiprazole, olanzapine, and risperidone. They did note that small benefits for global behavioral symptom scores does occur. And this is talking about symptoms of psychosis and agitation. The results were inconsistent and adverse effects were common in the elderly. So as far as adverse drug events in the elderly, what did we see? Weight gain with olanzapine being the worst, fatigue and sedation, common in all, akathisia, especially problematic with aripiprazole. It's interesting to point out that they also provided some data on number needed to harm, NNH. The number needed to harm is how many patients need to be exposed to a risk factor over a specific period of time to cause harm in one patient who would not have otherwise been harmed. So as far as looking at the increased risk of death, the number needed to harm is 87 overall. As far as increased risk of stroke, number needed to harm is 53 when we're looking at risperidone. So 53 patients need to be treated with risperidone to harm one. These are numbers that are very alarming. The increased risk of EPS, number needed to harm, is 10 for olanzapine and 20 for risperidone. So number needed to harm is increasingly being cited in evidence-based medicine. I also want to point out that cardiovascular symptoms were more common in olanzapine and risperidone than in placebo. When we look at mortality with antipsychotics, specific agents, numbers needed to harm, haloperidol is 26, risperidone 27, very similar, olanzapine up to 40, quetiapine 50. So this is why we were saying before that quetiapine may have the least risk, but the risk is also dose related. This study is a retrospective study that was from the VA system, 90,000 patients 65 and older with dementia, and they set out to determine here the mortality risk and the number needed to harm. So this is rather alarming statistics. Let's also consider what to do about gradual dose reductions. When we're using an antipsychotic, we need to be mindful of this. So there are several methods. One is abrupt discontinuation, and one is a slow taper, more than 2 weeks. Either one may be appropriate depending on the circumstances, the dose, the patient, the condition. But we do have to keep in mind that there are some concerns. There might be reemergence of behavioral symptoms, and there might be adverse drug events from withdrawal, dyskinesias, insomnia, nausea, or restlessness. So there's no formula or to use that's the best in all cases. The factors that we need to think about: what's the length of treatment, what are the target symptom or symptoms, what about the dose, and what about the side effects that are occurring. I wanted to also point out that we, of course, always need to rule out drug-induced causes of behaviors. And this is a partial list of drugs that can either worsen cognition or dementia or cause delirium. And you'll see by scanning through this that many of them are anticholinergic drugs, such as antihistamines, the muscle relaxants, H2 blockers, antispasmodics, and some of the anti-Parkinson drugs. But there are also a variety of other, and the urinary incontinence drugs, but there are also a variety of other drugs included. So this isn't a complete list, but it is something that can help us as pharmacists when we look at the drug regimen and think about drug-induced causes of behaviors. So to sum up our talk, what is our stepwise approach to antipsychotic use in the elderly? We consider drug-induced causes of behaviors or concurrent disease-related causes and attend to these first. Disease-related causes may be infection, dehydration, metabolic or electrolyte disturbances, of course, pain and depression. And when we look specifically at the drug regimen, we need to consider stopping unnecessary or potentially inappropriate or duplicate therapies. Also, we may consider that Any new symptom might be an adverse drug event. We can avoid drug interactions by simplifying the regimen, and we can watch for anticholinergic burden. So 1 + 1 is not always 2. 1 + 1 might be 3 or more when you use multiple drugs that have anticholinergic side effects. And we need to also evaluate the ongoing or continuous use of cholinesterase inhibitors. When we think about drug interactions, also think about both kinds, pharmacodynamic and pharmacokinetic, because both do play a role. I also wanted to point out that the new beers list, the American Geriatric Society edition of 2015, has an interesting table called Table 4, and this does list drug-drug interactions. And one of the main things that they point out in the new beers list table is that they suggest avoiding greater than or equal to 3 drugs with CNS activity. So what is our stepwise approach to antipsychotic use in the elderly? As we continue, documenting the problem behavior is key. We mentioned a couple of things that we could do about that. Knowing the ABCs is important. We spoke about that. And also just paying attention to the antecedents, the triggers, the duration of the problem. These all point to the question, what needs are not met? It might be physical, it might be environmental, psychological, or psychiatric. Behaviors also may change over time. So using non-pharmacological approaches first is the key. Caregiver, family, and patients may also provide input to make a personalized plan. Interventions are personalized and based on cognitive level, physical functioning, personality of the resident, and their interests and symptoms that are displayed. We need to review these interventions for specific behaviors and adjust as needed, either in the caregiver approach or patient or family approach. Maybe also changing the environment and using evidence-based interventions. So there is information about these evidence-based interventions, such as agitation or irritability might be best approached non-pharmacologically by a calming, soothing, or distracting demeanor using music or aromatherapy, or pets. Wandering or restlessness, for example, might be better treated by more engagement and distraction. Finally, our stepwise approach might include using antipsychotics. If we use them, we use the lowest effective dose, and we most likely use a second generation agent. But we do need to identify the target clearly. So avoiding non-specific terms such as agitation or aggression is advised because these can mean different things to different people. The key elements are that the behavior needs to pose a danger to self or others, and that we've exhausted other non-pharmacologic approaches. And of course, stopping if the drug isn't helping. We should avoid as-needed dosing. And we should monitor for side effects and toxicities that we've mentioned: EPS, vital signs and metabolic parameters, worsening cognition or psychiatric symptoms, sedation and oversedation, fall risk, urinary symptoms and constipation, and attention to drug interactions, both pharmacodynamic and pharmacokinetic. We need to document gradual dose reduction trials. What happens when we did? How is the patient? What is our next step? We need to monitor for outcomes and continue non-drug management as we use the drugs. So we continue an individualized and patient-centered process, involving the patient, if possible, and the family definitely in the decision processes. Here are some additional resources that you might want to review. Thank you very much. This brings us to the end of our discussion. Thank you for your attention.